Hello everyone, welcome to our next class, and this is on managed care. We have already talked about managed care in our history classes, and managed care really got going in 80s and 90s, and at the end of 90s we heard about the term managed care backlash. So managed care lost its footing in late 90s, but before that it rose to its zenith and really got the cost down. And in the 90s there was a steady growth of healthcare premium, which was much less than any time in time memorial. The three power of three words for this class are selective contracting, managed care backlash, and most favored nation clause. So we start with selective contracting. The name suggests that it is making contract with the selected hospitals and managed care organizations, mainly HMOs and later PPOs, preferred provider organizations, had the power to contract with selected hospitals. So it was assumed that this purchaser, that is HMOs, were able to exclude some providers from the contract. So it was highly selective, and it implies that in presence of selective contracting, more providers could result in lower prices. So the more the number of providers, there could be lesser prices. Selective contracting started in California in 1983, when the California legislature passed two laws dealing with contracting between insurers and providers. So the legislature allowed California's Medicaid program, that is called Medi-Cal, to enter into contracts with some hospital providers, but not necessarily all. The legislature also made it clear that a private insurer did not have to contract with all licensed providers in a given market. And after the enactment of the law, this study shows that cost in most competitive quartile rose least rapidly. You can see that where there was more competition, there was lesser cost. Another issue is whether lower hospital prices result in more contracts and greater patient volume at contracting hospitals. Feldman et al. In 1990 examined hospital contracting among HMOs in 4 cities in the mid-1980s. They tried to explain why hospitals got contracts as a function of price, quality, and location. They used hospital characteristics like teaching status, number of services provided, and ownership as proxies for quality, and cost as a proxies for a price. They found that price did not predict which hospitals got contracts. The quality proxies did. This figure shows the effect of HMO on the hospital costs. Before 1988, there was no effect of HMOs on the hospital costs, but after 1988, largely because of selective contracting, the costs were down because HMO were more dominant during that period. We have discussed this term favorable selection during our adverse selection class. So what is favorable selection? It's easy, that selecting the low utilizers as a plan member. So the question is, which one is responsible for decreasing the cost for HMO? Whether it is favorable selection, selecting the low utilizers upfront, or selective contracting. To find this answer, we look at a study which was conducted by Altman and his colleagues in 2003 using the 1994 and 1995 data from Massachusetts, and they looked at one indemnity plan, 10 HMOs, and one PPO, which offered to state and local government employees under age of 65. This table shows the actual incidence of the 8 health conditions across the indemnity and HMO cohorts. The incidence rate for all but cervical cancer was higher in indemnity group, The differences became much smaller when adjusted for demographics, but even then, the indemnity plan had enrollees with higher incidence of these conditions. Clearly, much of the difference in overall claims experience comes from the favorable selection that HMOs enjoy. This table shows the treatment shares for those patients with acute myocardial infarction. It is not clear that the HMO patients received less aggressive treatment. Finally, this table presents the difference in per capita expenditures for each of the 8 conditions and decomposes those differences into selection, treatment intensity, and price effects. Across all 8 conditions, 51% of the difference in expenditure was attributed to selection, 5.1% to lower treatment intensity, and over 45% to lower prices. Therefore, managed care plans can provide actual cost savings due to their ability to selectively contract with providers. We were talking about the managed care and hospitals' selective contracting phenomena, but much less information is known about the physician markets and contracting with managed care. So payment arrangements vary in different categories like bill charges, fee schedule, bill charges. So we saw that there are many different kinds of payment system, and those came into play for this managed care also. So we can see that if managed care effectively means selective contracting, then managed care plans should contract with subset of physicians, not all of them, in a given specialty in a given local market. So the physicians who get contracts presumably have agreed to lower prices, and managed care plans channel subscribers to them. The contract is likely to result in physician with contract getting disproportionately larger amount of patients and earning greater practice income. So the net effect is overall lower average earnings of physicians. This is a result from a study conducted based on the data from Orwell Johnson Foundation survey of young physicians, and they showed that physician income was a function of physician characteristics such as specialty and year of experience, the local demand for medical care, whether the physician was self-employed, and the proportion of local population enrolled in an HMO. So it is a common notion about hospitals and doctors who are charging more, and managed care tried to make this narrow path wider. So in conclusions, we can say that capitation reduced costs, while greater use of profit sharing reduced costs also. Gatekeeping, one important attribute of managed care, that is making the primary physicians to the referrals to higher hospitals or providers, did not translate into reduced costs. So use of clinical guidelines and profiling reduces costs also, and higher proportion of primary care doctors, that is dealing with gatekeeping, raised costs actually, and no economy scale beyond 8 to 10 physicians were found. Employer-sponsored health insurance premiums increased at an ever-decreasing rate from the late 1980s through 1996. A large part of this decrease was probably the result of the expansion of managed care and its use of selective contracting. From 1996 to 2003, premium grew at increasing rates. Two arguments have been advanced to explain the increase in premiums. One is the backlash against managed care, and the second one is decreased competition among providers. This flowchart shows how managed care backlash evolved because there were hassles to get to a physician or getting referred to a higher specialty physician, and that brought the distrust and fear among the patients. That translated into hatred and then market backlash from the from the patient perspective. Backlash came and provider also consolidated. We saw that the provider consolidation had another effect, and then came the regulatory backlash. So the reduction in competition argument says that a wave of hospital mergers and consolidations reduced the number of competitors and allowed hospitals to raise prices to managed care plans. Physicians have been accused of entering into managed networks that collusively raise the price of their services to insurers. So there were cartels in form of many hospitals or many providers charging together the same price. The evidence is mixed on the effects of managed care growth on consolidation among providers. However, there is little research on the effects of the wave of mergers on prices paid by the providers. So the FTC and the Department of Justice continue to have an active interest in anti-competitive behaviors in healthcare industry. So here we see the difference between monopoly and monopsony. We know all about that monopoly is a single producer who has this competitive advantage that there is no other competitor in the market. They can produce less and charge more, and they produce at the intersection of this marginal cost and marginal revenue curve rather than producing at demand curve, that is average revenue cost curve, and marginal cost curves intersection. On the other hand, monopsony is the only buyer. So in that market there is only one buyer, and in case of insurance, if there is one insurance only in one market, they can have this monopsony power. And they found that rather than operating on the market equilibrium, if they buy product at the intersection of marginal factor cost and demand curve, that is marginal cost curve, so that will be favorable for them. So there are two views of managed care. One is that through selective contracting, managed care plans have been able to overcome hospital market power and achieve lower prices for hospital services. The other view is that managed care plans have monopsony power and have used it to lower the prices that they pay hospitals. Now we'll look at the most favored nation clauses and its impact on health insurance. Most favored nation clauses came from the international trade regulation, where it says that a nation cannot be overpay for their traded product. So they will pay for the lowest price which one country is trading with another country, and they cannot discriminate prices for their same product which they prices less for another country to another country. So these are the most favored nation clauses in international trade agreement. So in healthcare market, if any provider provides a service at lowest price to any contractor, that is insurance company, then another insurance company will get the same price from the same hospital. These figures show the effect of MFN on expected probability of the hospital. So you can see that the expected profitability reduces after the MFN clause comes into effect. So MFN reduces a hospital's optimal discount offer to an HMO because they cannot decrease their cost that much according to these laws or clauses. And MFNs also reduce the overall profitability of engaging in HMO discounting at all, because the discounted rate is there, so HMO cannot make further discount and make further profit. So there are trade-offs between deep discounts for a few HMO versus shallow discounts for many. One claim is that MFN harm competition by either enforcing a cartel arrangement among providers that keeps prices high, or by restricting the ability of new managed care plans to negotiate lower prices with providers, which benefits large established local insurers. Others say that MFN clauses are mechanisms to allow insurers to obtain acceptable prices in market with considerable uncertainty. MFNs can be explained with the analogy of the new car, that everybody knows that no one pays sticker price for a new car, and also no one can buy the car below the dealer's cost. So the dealer will not sell his car below their price, their cost. So at the healthcare market, everybody knows, the insurer knows that hospitals' charges are not the actual price. They will sell at discounted price, but there is a threshold value below which the hospital will not sell their services. So that is the MFN. So thank you very much for your kind attention. Now the managed care is not out of context. We are talking about affordable care organization, that is another kind of managed care, and we are euphemistically saying new thing because managed care has this stigmatized. It has been due to their backlash and this cost containment thing. So managed care did well to reduce the healthcare cost, but got out of context because of its negative connotation. Now under the Affordable Care Act, we are seeing new surge of affordable care organization, which is another type of managed care, and in the next few years we'll see the surge of this kind of organizations. So thank you.